Office of Rural Health. And in lieu of our in-person forum on aging in rural Oregon this year, we've done a series of smaller sessions that are relevant to the things that are going on in our world right now and otherwise. So before we go ahead and get into the content, I want to thank the partners who have stuck by our sides during these kind of wild times. Our Central Oregon Health Council, Pacific Source, St. Charles Health Systems, Samaritan Health Systems, O4AD, Oregon DHS and People with Disabilities, Adventist Health Tillamook, Peace Health, Gobi, and Columbia Memorial Hospital. Next slide. So a few housekeeping tips and orientation to WebEx. The audio and video for you all as attendees are muted. If you have any questions throughout for our presenter, you can use the Q&A function. If you have any issues, please chat with me on the side and I'll help you figure those out. I'm going to be the moderator for the session today. So as you have any sorts of questions, pop those in the Q&A and we'll get those to Liz at the end. The slides and this recording will be posted at the web address listed on this slide. And do know that Liz has a jam-packed session for you today. So if there's a slide that she moves over quickly or information that she covers quickly, please do know that the recording and these slides will be sent out to you later. Next slide. So without further ado, today we have Liz James. Liz is a respected member of her community and very involved with AARP Oregon, the Southern Oregon Action Team, co-chair of LGBTQ Health and Wellness Summit of Southern Oregon, and a member of the of Oregon Statewide LGBTQ Aging Coalition and RVCOG, STC, so the Senior Advisory Council down in Southern Oregon. That's a mouthful there. So Liz is going to speak to us today about LGBTQ plus older adults, aging, cultural competency, sort of the nuts and bolts 101 and tools that you all can use to improve patient communication, care, and outcomes. So Liz, I'm going to let you take it from here and I'll mute myself. Thank you so much for joining us.
Great. Well, thank you, first of all, to the Office of Rural Health in Oregon, and also Rose, you're wonderful. Thank you very much. And for everyone on the line, please know this is a lot of slides because this is a robust topic covering a very diverse population. And again, you will get these slides. I want you to know that I'm a data nerd, self-avowed, and I believe in evidence. And although we need way more evidence about LGBTQ plus populations, I have endeavored to bring forward in my presentation as much evidence-based information that I can find. And in the slides that you will get, there will be hot links so that you can pursue those. This is a 101 session, so part of the expectation is that hopefully there'll be a commitment to move beyond this and to learn more. So without further ado, if everybody's ready, I'm ready. So I have no conflicts to disclose, and today I'm going to talk very quickly about some of my relevant background, who are LGBTQ plus older adults, policies, terminology and identities, disparities and challenges, and how you actually create a welcoming environment. And there you'll get a voluminous amount of resources, which I won't be able to go through completely. The objectives, again, are to be able to describe disparities faced by LGBT older adults, explain how policy changes can improve health and care and elder services for this population, and describe how health systems, including providers, can advocate and care for LGBT patients. So my background, it's pretty varied. First of all, I'm 65 years old. I came out as a lesbian when I was 18 years old. And in my most recent past life in Texas, I ran a nonprofit called the Lesbian Health Initiative. And you're looking at a photograph, one of my very favorites. It's a diverse population. It took a diverse group of us to actually serve the community. Our goal was to eliminate the barriers to healthcare for LGBTQ identified women and trans men. Just a couple of things to note about that. The programs are actually written up as evidence-based programs that can be replicated in Health and Human Services AARQ. So that'll be available in the slide deck as well. And last but not least, we were very focused on our advocacy work as a part of that. And I was really pleased to have been invited to bring data forward to Houston-Harris County is biennial state of health report. And what you see here were very specific health actions that were asked of those reading this report. And it was the very, very first time that there was inclusion of sexual orientation and gender identity in this report. So how many of us are there? The best data that we have from an adult perspective in the US is there's about 10.4 million adults that self-identify like myself as gay, lesbian, or bisexual. There are about 1.4 million adults who identify as transgender. And across the United States, over 11 million US adults identify as LGBT. And the best number, and I think it's a bit low, but in terms of percentage, is 4.5%. So when you look at Oregon, the total population is over 4 million. Of those, 3.3 are adults. And the best data that we have, according to estimates by the Gallup and the Williams Institute and the 2018 census, is that about 190 Oregon adults identify as LGBT. And of those, about 20,000 identify as transgender. And I think this is important to note. Oregon is second in terms of percentage in the United States, only behind Washington, D.C., in terms of percentage of adult population. And I think it's also important to note that we're a population that also raises children. So let's talk about the older adults. It's really important to note that we live in all parts of the community. And I just wanted to demonstrate that there's actual data, thanks to AARP, that shows that we live in both small and rural communities as well. And there's additional data that you'll get. There's a wonderful organization called the Movement Advancement Project, and they publish all kinds of reports. And this is a wonderful report about where we call home. And they've identified that there's 2.9 to 3.8 million LGBT folks that live in rural America. They also have a great report about transgendered folks who live in rural America. And it's also really, really important to note that LGBT people of color also live in rural America. So let's look at who are all these LGBTQ older adults in the US? Well, the best estimates that we have that there's about 2.7 million LGBT adults age 50 and over. About 1.1 million of those are 65 and older, and approximately 1 in 5, or about 20%, are people of color, and 1/3 live at or below the poverty level. Now, when we look at the older population, well, before I move on, it's also a population that's growing, and so the estimates are by 2030 that that number will grow as high as 7.2 million. Now, it's important that you know, first of all, LGBTQ is not one word, it's not a monolith, and certainly older adults are not a monolith. There are 3 generations. So we'll start with the first and the oldest of the old. It's the invisible generation. They came of age during the Great Depression. Many of them fought in World War II. And it was a time where people were really non-existent. It's why it's called invisible. And I will tell you, when I came out as an 18-year-old, I met a number of these folks. And something that I want to note about these folks, there are folks in this category that if people did find out about them. I knew several people who had been institutionalized and had shock therapy as a result of people believing that there was something not okay about them being LGBT. Now, when you look at the next generation, it's the silent generation. It's the greatest generation, age about 75 to 80, came of age in the 40s and the 50s. And keep in mind, in the 50s, it was the McCarthy trials, there was the Lavender Scare. It's really when basically sexual and gender minority folks became criminalized. So it drove people really into the closet, if you will. And it was also a time in 1952 where the American Psychiatric Association classified homosexuality as a psychiatric disorder. Then you get to my generation, it's the baby boomers, the pride generation. They came of age when a whole lot of things were happening. Many of you probably know about Stonewall riots in 1969. And in the 60s, there was the beginning of decriminalization of same-sex behavior. And in 1973, they finally removed sexual orientation as a psychiatric disorder from the Diagnostic and Statistical Manual of Mental Disorders. And huge to me, and most of us, in the 1980s, the pandemic, the AIDS pandemic began. And I'm somebody who in 1985, I lost my very best friend to a horrific, horrific death. And also my brother died in 1993, and I knew so many other folks that were lost. So this is really important to keep in mind about people in that age group. And it's also important to note that LGBT people are people with disabilities. It's estimated that 3.5 million have disabilities, and new research shows that we are more likely to be disabled. In a big survey of transgender folks, which happened in, I believe, 2015, 39% reported having a disability, and 1 in 3 lesbians and 1 in 3 bisexual women report in a survey in Washington report being disabled. It's also important to note that in the rural community, the data set that I had shows that transgender folks are 3.5 times more likely to be disabled. So one of the things I want everybody on this call, and I want you to tell everybody you know, LGBT folks are not a community. It is an inappropriate word to use. And it's not one word. The reality is we are part of all communities, and we are a very diverse community. We are every ethnicity and faith. And this particular slide shows that even if you just look at the poverty level, you can not only see some of that diversity, but the poverty doesn't impact folks the same that are of the LGBT community. So for example, 48% of transgender adults are at or below 200% of the poverty level, compared to 40% of all LGBT adults over 80. I also wanted to point out that in rural communities, and I think this is part of everybody, but certainly LGBTQ folks have higher rates of poverty, and in fact, 1 in 5 compared to 1 in 4. So let's, again, this is one of my big issues. It's not one word, not one community. We reside everywhere. We are all faiths and ethnicities, and we fall in all categories. So why do we need to know who our LGBTQ patients are? Well, it provides you an increased ability to know your patient and have information about them, their health risks, the support systems. And the reality is those who come out are more likely to access care. All the physicians that I've ever met in all the work I've done, they just want their patients to follow protocols. Well, that's really, really important. And so some of the statistics that are out there show that women who were open with their primary care doctors and gynecologists were 2.5 to 3 times more likely to have routine screening than those who did not. Important to note, there's a long history of anti-LGBT bias in healthcare, which still exists. And I'm going to zip through some of these data points because we've got a ways to go here, but I've got corroborating evidence about that. So when you look at the adult population, a lack of competent, inclusive healthcare will and can result in poor health outcomes. Some of the data that we have shows in a report that was done again by the Movement Advancement Project that LGBT older adults between the age of 45 and 75, 36 reported that their primary health care providers were unaware of their sexual orientation. there were 23% that were reluctant to discuss certain issues for fear of being judged, and 20% feeling that their relationships or with other providers, if they shared who they were, that would adversely impact them. There's also great data sets about transgender older adults. As you can see by just looking at the bars, transgender folks, along with people of color, suffer higher levels of challenges and are disproportionately impacted by various things. So I wanted to make sure, when we are talking about caring for this population, it isn't that we just do it out of the goodness of our hearts, which we absolutely need to do, but there are very specific policies that require us to take care of our patients. So I'll start with the Affordable Care Act. I had the privilege of being at the first, and it might have been the only, White House conference on LGBTQ health in 2012. And at the time, Kathleen Sebelius was the keynote, and she actually stated the Affordable Care Act may represent the strongest foundation we have ever created to begin closing LGBT health disparities. And in reality, this has proven to be true. Under the ACA, uninsured rate for LGBT individuals making less than $45,000 per year has been cut in half. And actually, way more of us have been insured as a result. And I was one of them. I went from being in private employment to working for a nonprofit. And because I had changed, before the Affordable Care Act, I could not get insurance because I had pre-existing conditions. So it's really important to note, and I think we're probably all aware that the ACA is going to be, there's a case with the Supreme Court, and a whole lot of folks will be jeopardized. In fact, you could say all of us will be jeopardized if that is ruled unconstitutional, but certainly it will jeopardize the health of more than 20 million Americans, including the LGBTQ folks. So I think it's really important to note, and many people forget that marriage equality is still pretty new. This happened in June of 2015, that the Supreme Court ruled that same-sex marriage was the same as different sex marriage, and that Medicare now applies to all of those folks that have been married. Now I'm going to stop and let you know that there are going to be older LGBTQ folks that have been together for 10, 20, 30, 40, maybe 50 years or more that are together, but they may not have chosen to be married. So it's really important to note that. I also think it's important to note that the Older Americans Act actually prioritizes service to at-risk older adults that include LGBT older adults. And Oregon, through many DHS, it's basically integrated in Oregon, and I'm thrilled. I'm a Texan, and for many, many years, I've been here 5 years, and I think Oregon has some of the best inclusive policies in the country. So many people don't know that the Oregon Health Plan on January 1st, 2015, extended coverage for transition-related healthcare, transgender-related healthcare. That services include puberty suppression, primary care and specialist doctor visits, mental health care visits, cross-sex hormones and anti-androgens, lab work, and some surgeries. Really important. Also, there's specific guidance to the insurance industry that provides that they must address issues related to transgendered persons in terms of making sure that they are not discriminated against. Also, Oregon passed the Reproductive Health Care Act, and really important, particularly to, and this is a great example, it prohibits discrimination on the basis of sexual orientation, gender, identity, and here's a great example. An individual who is assigned female at birth and identifies as male goes to get cancer screening or perhaps a mammography, and his insurance only covers screenings for females. Well, this act requires that that person get those screenings and get them covered, and that's also true regardless of what name that person goes by or how they identify their gender on different documents. Really important. So What do you have to do to be culturally competent? Well, you don't have to be an expert. You just need basic information. You're here. I'm hoping that to provide that to you, a willingness to learn, and it is absolutely critical, and this might be the most critical, that you have an openness to hear and be present with what your patient is trying to tell you. Now, I will tell you, I'm going to cover some very basic things here, so those that know these basic things, bear with us. So the terms: L stands for lesbian, it's a sexual orientation. G stands for gay, it's a sexual orientation. B stands for bisexual, it's a sexual orientation. T, transgender, it's a gender identity. Queer is being used by a lot of young people today. It's a term that I just recently was able to say because it was a derogatory term for me as a youngster, and you'll find most older adults probably don't use that term. In fact, they may not use any of the alphabet letters. It's also important to note there are other letters. Q can be questioning, I, intersex, 2S, two-spirit, a Native American, indigenous term, asexual, same gender loving, and pansexual are other terms. So, sexual orientation, how a person identifies their physical and emotional attraction to others. Again, lesbian. I'm a lesbian. I'm somebody who has a primary sexual and romantic attraction towards women. Gay is an identity label for men who have a primary sexual and romantic attraction to men. Now, I will tell you, I didn't like the term lesbian for years. I just didn't like the way the word sounded. So I called myself gay. So these are not absolutes, and you just need to be aware that many women will refer to themselves as gay. From a research perspective, it definitely refers to men who are attracted to men. Bisexual is an identity label for people who have an attraction to either men or women. Pansexual, it's an attraction regardless of sex or gender identity. And queer, again, is a word that describes sexual and gender identities other than straight and cisgender. And it is evolving. Cisgender is a person, I'm a cisgendered woman. I define myself, identify as a woman, and I was assigned female at birth. So, sex, gender, and gender identity. Sex, biological and anatomical differences. And some people don't fit into male or female. They are intersex. There's gender. It's a social construct that refers to the rules and norms society assigns to varying degrees of male and femaleness. And gender identity, a person's internal sense of their gender. Do I feel male, female, both, neither? It's a feeling that typically begins early in life. Gender identity, all of us have one. Again, it's an internal sense. And for many, this matches the sex assigned at birth, cisgender. For transgender people, it does not. And gender identity may or may not match, and this is really important, one's appearance, body, or others' perceptions. So I like to tell this story. You know, I'm somebody, if you've ever heard the term gaydar, I don't have great gaydar. And I just want to point out that you can't decide who somebody is based on how they look. And in Texas, you know, it's pretty rural. There's rural parts of the state, and there were women who worked on ranches that looked really, if you'll excuse the term, butch to me, and I thought they were lesbians. Well, they were not. So it's really important to remember it may not match. Sorry about that. So gender expression, again, how one presents themselves through behavior, mannerisms, speech pattern, dress, and hairstyle may be on a spectrum. Transgender people, their gender identity is not congruent with what was assigned at birth. There's alternate terminology. So a transgender man, this is a person who was assigned female who just defines himself today as a man. It can be, you may see the term FTM. Transgender woman, somebody who was assigned male at birth, but today defines themselves as a female or a woman. Trans woman, male to female terms. Then there's non-binary, genderqueer, gender neutral, somebody who doesn't identify on either side, male or female. This is opposed to an intersex person. This is an intersex person may also define themselves as genderqueer or non-binary. Then you have transmasculine, transfeminine are terms, and a person may decide to transition at literally any age. And really important, they may or may not change their pronouns. Also incredibly important, they may or may not use hormones or have surgery. Finally, it is really, really key to know that gender identity and sexual orientation are not the same thing. All people have a gender identity and sexual orientation, and the reality is how people identify can change and terminology varies. Once again, gender identity is not the same as sexual orientation. So again, it's not always obvious who is LGBTQ. And in fact, if you have intake forms, the form may not tell you what you need to know. And in many cases, it's okay to ask questions. And I want to preface that by, you have to really pay attention to your patient. There are some older patients that are not going to want to reveal that, particularly the oldest old. So it's really important to listen and ask questions about partners. I'm going to have some tips on how you do that and what their name is they'd like to be referred to as, and preferred pronouns. With trans folks, it is absolutely critical that you use the language they use for their body parts. We got to listen. And I will tell you, it's okay to feel awkward as you learn to ask. The nonprofit that I had the privilege to run, we ask our patients that we did these big screening events, and we on intake had to ask these questions. I wore many hats, and I had to ask those questions. I will tell you, I obviously am a lesbian, but I felt awkward. So it's okay to feel awkward. So let's talk about barriers to healthcare. First of all, there's limited access. So the reality is that the population, LGBTQ population, still has a higher percentage of being uninsured, and they may lack, and they do lack, safe healthcare options. And they may or may not have access to spousal benefits. Also, you may not have a healthcare provider who knows the risks and the issues that LGBTQ folks face. Also, you might be afraid to share your sexuality or sexual history. And there's the issue of multiple stigma. If you are of a different race, if you are disabled, maybe you might be Muslim, there is this whole multiple stigma of the intersectionality of those things that cause additional barriers and challenges. And the reality is, many of us don't understand our own risks for health issues and disease, and we may not even know where we can get care. So again, when we look at the rural setting, not accessing healthcare due to anticipated or internalized or enacted stigma, privacy and confidentiality concerns. And I will tell you, I lived as when I was in high school outside of Cleveland, Oklahoma, and my entire family, there was one doctor, and all of us went to that same doctor. He was a great guy, but I think we can all imagine why somebody might not want to share something about themselves, about their sexuality, sexual orientation, or gender identity with a doctor that their entire family goes to if they're afraid that that will be exposed. So again, patients not disclosing sexual orientation and gender identity, which will definitely, depending on the needs, potentially impact whether or not they get the important care they need. And the reality is there's limited training still across the board, but this is really higher in rural areas. And the reality is provider bias and discrimination exists. If it exists in Houston, and where the largest health center is in the United States, and some of the biggest hospitals, and I have a lot of stories, including a transgender couple. One of them had a heart problem, went to one of the leading heart hospitals in Houston, sat in the waiting room with pain for like 2 hours, and finally got up and got ready to leave. And if it hadn't been for a nurse who came over and said, "Wait, I will find you a provider," the reason they were sitting there is the provider did not want to see them. In addition, one of the other stories I have to share is a transgender person and went to an ER. And they were somebody who, there's a term, pass. They didn't pass. So they look like a transgender person. Well, the custodian saw this person and like ran around to tell people, you wouldn't believe who we have in ER. You know, just a gross violation of privacy. And as you can imagine, how would you feel if you were in ER that vulnerable and that was happening to you? So these things, just two anecdotal stories that I know about, and there are a lot of them. I think it's also really important to note, again, that if you're Black or Latino, we've got some data that, you know, it just really compounds the discrimination concerns. And in some cases, the first thing a person has to deal with is the color discrimination that they're having before they even get to sexual orientation. So really important to note, and this was data from the AARP 2018 survey. So what kind of disparities and risks do this population face? Tobacco use, higher use of tobacco, higher use of alcohol, mental health issues, particularly anxiety and depression, cancer, obesity, cardiovascular disease, HIV, although HIV is not a gay disease, as I like to say, there are definitely populations within the LGBTQ alphabet, including people of color and trans women, that have higher rates. And there are increased drug use. And there are dramatically higher cancer risk factors that include tobacco, alcohol, obesity, null parity, higher amounts of estrogen in your body if you've not had children, HPV, and that's men and women, HIV, and lack of access. So when you look at smoking rates, this is a pretty stunning piece of data. And this tells two different stories. First of all, you know, it's very clear that LGBTQ folks, based on the data that I'm presenting here, have a much higher rate of using cigarettes. And one of those reasons is that we were a targeted population in terms of marketing. So there's a photo on the left, and, you know, if you were a gay man and you saw this, you'd feel validated by this. I think we all know that children are a big target, particularly with vaping. So that's one thing. And smoking, you know, is a stress-related behavior from my perspective. There's definitely increased mental health risks. This is a pretty stunning piece of data here, and this was produced by the Mental Health of America and USC Social Work. The LGBT individuals have 1.5 times higher risk of depression and anxiety disorders than heterosexual individuals. LGBTQ folks have dramatically lower screening rates for cancer. That includes mammograms, and, you know, this is the entire age spectrum, and cervical pap well-person exams, lesbian and bisexual women. There was a research study that showed they were 10 times less likely to have a pap test. And I will tell you that there are OB-GYNs out there that don't think lesbians need a pap test. They don't understand how HPV is transmitted. You don't have to, you know, first of all, lesbian might have had heterosexual sexual relations, but that is not the only way you transmit HPV. Anal pap smears, many folks, providers don't even know about them, really important for HPV detection, and low rates of colonoscopies. It's also, I think, important to note that LGBT older folks suffer from dementia as well, just like heterosexual population. The best data set we have is 7.4% of that population is living with dementia, and those risk factors are all those that I've currently mentioned that are part of the general risk factors from a health perspective that the population faces. And the reality is LGBT adults living with dementia face additional and unique challenges that include that they have smaller support networks over time, and there's a high percentage that live alone, and there are just lower rates of access to care. And, you can imagine part of that is because we don't feel safe. So let's talk some more about understanding issues facing LGBT older adults. So what are the cornerstones of successful aging? Economic security, social connections, health and well-being. Key challenges for LGBT older adults. Well, when you look at economic security, a lifetime of discrimination, housing, employment, lack of legal and social recognition. And although this is much improved in Oregon, I think it's important to note that not only do agencies not necessarily know that they are obligated in the state of Oregon not to discriminate, the people that they are meant to serve, the LGBTQ folks that they're meant to serve, may be unaware that they should be able to have access to things. Also, there's a real reliance on chosen family, and that can be due to family rejection. I got to tell you, I knew men who died of HIV alone without their families. And, I knew women who had been married. You'll find many older LGBTQ folks were married and are now not married. And they lost I knew folks women who lost their children. So a whole lot of things that have happened. And so that we've created our own social networks. And there is increased isolation. And again, long-term discrimination. So, older LGBTQ adult health issues and risk. We are twice as likely to be single or living alone, more likely to be estranged from our families, 4 times as likely to have children, more likely to be caregivers for our friends, more likely to have problems like HIV, depression, and substance abuse. Again, the high levels of poverty. We have a high expectation that healthcare providers will discriminate against us. And we actually do face high levels of discrimination in assisted living and affordable housing facilities. So additionally, I'm going to repeat some of these things, so bear with me. As the data sets I've shared, I think demonstrate there's an elevated risk of social isolation. Income is not commensurate with education. There is more of a lifetime of discrimination and victimization, higher rates of physical limitations, weakened immune system, mental distress. Lesbian and bisexual women have higher rates of disability, cardiovascular disease, being overweight, poor general health. And bisexual men, twice as likely to live alone, higher rates of risk of cancer and HIV. Transgender older adults, higher rates of discrimination, victimization, mental distress, poorer health, and less support. Bisexual older adults, higher stigma, less likely to disclose identity, lower income, less support. And, this is a good time to point out that it's, even within each letter of the alphabet, those aren't monoliths, but there are different risks according to different letters of the alphabet. Bisexual people smoke at a higher rate than lesbian and gay men. So it's really important. There's a reason why as providers, we need to be educated and understand these populations. And older adults of color and those with lower income and education obviously have an elevated risk of health disparities. And I think we really are learning a lot more about that with COVID. So I did want to just provide a little bit of data. This is a study that was done, and this is just some data points about some of the experiences that older LGBT adults have faced in care facilities. High levels of verbal and physical harassment, refusal for admission, staff refused to accept medical power of attorney from resident, spouse, or partner, restriction of visitors. So the reality is these things are happening. Also, I just was so thrilled that AARP did this survey. There's a real difference in terms of what's accessible to LGBTQ folks, depending on what type of community that they live in. The yellow bar indicates people have access, LGBTQ have access to resources, and just across the board. And the blue bar has to do with senior resources. And, you know, I can tell you in rural Oregon, it's less than 10% probably. Also in rural situations, it is much more difficult, you know, if you can actually find health care, to find health care somewhere else, if you're discriminated against. So this is just meant to show that the options are limited, and it is absolutely important that people have a safe place to go in order to get the care that they need. Also, and I can tell you that, you know, this is a great slide, you know, if we were in maybe California, because there are LGBTQ health centers, and, you know, in rural Oregon, and including in the Rogue Valley area where I hail from, you know, we don't have a specific LGBT health center, although I think we've got a couple of our FQHCs which are trying to do a pretty good job. Also important to note, transgender people are significantly more uninsured, and if I can, in rural, so it's really important, and I think the job that we have as providers is, you know, helping folks know that they can get on OHP if they qualify from an income perspective. And the reality is transgender folks have a much higher rate of being at or below that 200% of poverty level. So we have a job not only to understand that, but also if we have transgender folks, or that we educate other folks that those services are available here. So just some other data points about transgender folks in rural areas. One, and this was a small study, and keep in mind this wasn't a study in Oregon, and there will be news coming out shortly about a statewide study that will be conducted to better understand older LGBTQ adults. So, you know, stand by for a press release on that, I hope, in the next month or so. But keep in mind that these percentages are, I believe, are much higher in a state like Oregon, in our rural areas. 23% said they had to teach their provider about transgender people in order to get the care that they need. I think that that's grossly low in most areas. And 14%, and this is really important, have providers that ask unnecessary or invasive questions about their transgender status. And this is important to note, you know, the way you engage your patient, if they're there for a runny nose, you know, whether or not they are transgender has absolutely nothing to do with treating that. 11% had providers who actually refused treatment. So just some data points about transgender rural health care. So I'm going to take a little sip of water here, like you needed to know I was doing that. So let's talk about what we do to create a welcoming environment. These two photos are actually from these health fairs that we produced when I was running a nonprofit in Houston. So from an individual and a practitioner level, you don't want to assume anything about your patient, their gender, their identity, or their sexual orientation, or their relationship status, whether or not they have HIV or AIDS. And you really need to change your language to gender neutral language, partner and spouse. Mirror the language people use for themselves. Show your openness, assure confidentiality, really important. One of the pieces of advice we have is to have literature, and I'll have an example of that. You and all of your compadres need to learn more about the community and about our health risk and our families. And when you do meet a transgender or non-binary customer, ask for a name. And in fact, I think this is just generally for all customers. What is the name you prefer to be called by? So you might have an older patient who won't self-identify as LGBT or transgender, but they'll give you their name. So that's really important. If unsure, politely ask for the name and the pronoun they would like you to use and listen and or ask for preferred names of their body parts. Avoid, again, unnecessary questions. And in case of a mistake, just say you're sorry and didn't mean to be disrespectful and move on. So just some examples. Instead of, are you married? Are you in a relationship? Are you seeing someone now? Do you have a significant other, your partner? You may find that a couple may say, this is my roommate, right? So keep in mind, this is, again, these are not absolutes. I'm going to skip through some of this. And instead of using a gender name found in forms, be respectful again and ask that pronoun. It's okay to make mistakes. And some organizational level changes to make. Again, provide the visible symbols. Yeah, we have like radar, we go in. So you may see all are welcome here, or rainbow sticker that can go up so we feel safe coming in. Customized patient intake forms. There's actually some guides on how to do that, to include sexual orientation, gender identity. Incorporate all the defined family members into treatment and recovery process, and if at all possible, have a list of referrals. And, implement an LGBTQ task force or committee so that your practice actually can adhere to growing their competence and maintaining it. So this is some recommendations specifically for older adults. Really important to have inclusive policies so that LGBT older adults can be specifically addressed in education and outreach. Make sure that the policies are inclusive of, again, chosen family. Transgender older adults should be gendered correctly. This is absolutely important, and treated with respect, and inclusion is medically necessary. Address specific health needs and mental health needs. So some of the resources that are available in terms of practice, this is a great report on basically recommendations for group patient-centered LGBT care in rural and multicultural practices. And this is information specific to how you can, actions you can take to improve those practices. Again, change the office environment to include LGBTQ information, use the appropriate terminology, encourage respectful, direct, and open-ended questions in patient-provider interaction, and provide staff training for all staff, and really reflect on your assumptions and biases and preconceived notions. We all have them. So this is a wonderful example of something, a piece of literature. It's actually an entire guidebook that AARP publishes that's a prepare to care. I know our local AAA that I sit on the Senior Advisory Council for has this in their lobby, but you could do it in a medical setting as well. And available, you can order those from AARP or reach out to your local AARP office. And there's a tremendous number of other great resources. Promoting behavioral health of LGBT older adults. I'm going to cover the both Oregon resources and the national resources where you'll be able to access all of these guides. And this is really neat. This is pretty new. This is the one and only and first guide to LGBTQ inclusive hospice and palliative care. I actually have a copy of this book. It's a wonderful book. And here's a guide to help you understand and learn how to ask questions about sexual orientation and gender identity in terms of data collection. Other suggested changes: post and enforce LGBTQ plus inclusive non-discrimination policies, offer staff continuing education, hire us, make us part of the staff, collect the data, and pursue human rights campaign healthcare equality index rating. So I will tell you, I've got a number of other slides, so I'm going to zip through some things because we want to get to the point where we can answer some questions at the end of this presentation. So bear with me as I move quickly through some of these slides. Again, all this information will be available online after, as Rose said earlier. So Oregon resources. There's SAGE Metro Portland, and when you get this, these are hot links to these. I am just thrilled to death that the Oregon Home Healthcare Commission has a wonderful diversity awareness challenges facing lesbian, gay, bisexual, and transgender adults training. And it is available to AAAs and to others. It's a pretty small fee if you're not actually a part of providing home care. But I would really recommend that as a state resource. It's great. There's actually a biennial LGBT health conference in Portland, and it's supposed to be next year. With COVID, that may change. A great resource for training, and they don't just do AIDS-related health training. They do a broad range of LGBTQ training is the Oregon AIDS Education and Training Center. And for those of you that don't know, we've got a wonderful transgender health program at OHSU. I know some of those folks came to Southern Oregon to do presentations at the conference we had here. So there might be folks, not only is that a resource for people to get care, even though they've got to go all the way to that facility, there are resources there. Also, Oregon has an LGBTQ veterans coordinator, Nathaniel Bohm, and they provide a broad range of resources, and we have a number, the VA has done a pretty great job of providing healthcare for LGBTQ vets, so reach out to that website. And I'm pretty pleased the Alzheimer's Association had just recently started a virtual support group for LGBTQ folks in Oregon and Washington. And that's a link to that group. From a national perspective, for more training, as I said before, this is a 101 course. The first one listed, there are just a ton of free courses, webinars that you can get continuing ed credits for, the National LGBT Health Education Center. And there are SAGE is like the National Older LGBTQ Adult Organization, a ton of resources that I've actually cited. There's the National Resource Center on LGBTQ aging. There's a hotline. The research report that was published, I showed you some of the data from that 2018 survey that AARP did, and then the guide that you can leave out, you can use for yourself or your clients or leave out in your lobby. So I'm going to come back to this slide. I'm just going to kind of zip through a couple of slides to give you a flavor of what you get. There's a ton of resource slides that come after this, but we have a Southern Oregon conference that the next one was to be next year. We're working on dates for that. So if you can't make it to Portland, we will have a health and wellness conference for healthcare providers here in Southern Oregon, hopefully in 2021. It may be delayed. Meaningful Care Conference. This is that virtual support group. This is the training course. This is really important. This is the Bible for transgender healthcare. It's available. It's the WPATH, World Professional Association for Transgender Health. It's free. It's available online. So if you don't know how to treat your transgender folks, this is going to be a key resource. AETC, Transgender Health Program at OSU, a ton of resources. I'll just kind of zip through. So I think we got about 5 minutes left. Sorry, I just zoomed through those things, but I really wanted to make sure we had the opportunity to, I had the opportunity to provide that groundwork. So thanks for your attention, and I'm open to Rose if there's any questions.
Yes. Well, thank you to everyone who has joined us today. I'm just delighted to have had Liz do such an amazing job here and to have such attentive attendees with positive, just great feedback and interaction. You know, they say there's something to be said for saving the best for last, and between Liz presenting this much needed, well thought out information, and then just the group of folks that we've had today. Thank you so much to both of you. So lots of appreciation for the resources from the attendees that we have on the line today. We've got a question about the non-binary folks, and I know you touched on this briefly, Liz, but do you have any more information to share on non-binary and where they fall into the LGBTQ plus spectrum?
They're in the transgender spectrum as a gender identity. I think many of you may know, or maybe not, that in Oregon you can actually be a non-binary. You know, don't define yourself as male or female on your driver's license. And I will tell you, just a personal story about that. When I was a little, I didn't really, I wonder today if I was a young person, if I would identify as non-binary. Even when I was little, itty bitty, I didn't really identify. It wasn't that I wanted to physically be different, but I didn't really identify with girls. And, I tended to be more of a tomboy, but I felt very androgynous. And that was the best term I ever had for that. What's wonderful today, being somebody who's been out so long, is young people, people can actually be who they feel like they are. So hopefully that answers the question. It really is a gender identity. Appreciate that question. Also appreciate that people found these resources helpful, and I hope they'll be used.
Yeah, we've got Sean saying, Liz, thank you so much. Amazing presentation. He'll share with everybody at DHS. Can't thank you enough. So I think that this information is just so appreciated and much needed. Is there any movement nationally or in Oregon towards requiring standardized data collection of patient information that indicates acceptable language for gender identity and sexual orientation that is acceptable to patients and health systems, for better tracking of disparities and health outcomes among all populations? And do you think such an effort would be beneficial to get better data?
It absolutely is a must. This is one of those things where I could have spent, 15 minutes talking about what we call SOGI collection, sexual orientation and gender identity. And I will put, there already is information specific to this in the slide deck and in my resource deck. In fact, let me just see if I can zoom forward to, excuse me, you probably go crossing your eyes while I do this.
As we get to the top of the
the reality is, yes. So I know that FQHCs are required to collect that. There are standardized questions, and there are tools to do that. And the reality is, if we don't collect that data, we don't understand who those folks are. We don't understand what their issues are. We can't get money to further research it. And as we all know, medicine is an evidence-based methodology, and we don't have enough evidence. We're slowly getting there. And I will tell you, during the Obama administration, there was a lot of focus on this. So SAGE, in most everything, we've got to collect the data. Now, keep in mind that somebody may not want to share it, so we need to be very sensitive to that. We need to be collecting it, and yes, there are standardized ways to do that. And in fact, at our local AAA, we added a set of 3 questions to collect sexual orientation and gender identity on our survey that informs our area plan, and all the AAAs, all the area agencies on aging are working on those plans right now. So it's not just in the healthcare setting. It's really important that we collect that data. And for anybody that's with a AAA, I will put together a set of slides specific to that. I've got a whole lot of resources for AAAs.
Lovely. Thank you, Liz. I know we do have some folks from AAAs or those that serve folks from AAAs, so much very valuable information coming from Chris, and I know that Chris does a lot of work with the folks out in the community. So that brings us to the top of the hour. I can't believe you got through all this information in 60 minutes, so it's time for questions. So very nice job. And we looks like we are losing a few folks, but held steady to the end. So thank you all. Keep an eye out. I will follow up with you all to share the slides, and a recording of this session will be available. Lots of thank yous coming in here, and please, if you have any suggestions or feedback or additional questions come up, you can reach out to me, and we'll make sure that any questions that you have get answered. So thank you so much for joining us today, folks. Have a lovely remainder of your day and upcoming weekend. Thank you, Liz. Thank you so much for your expertise here today and sharing in such a positive and humorous way.
All right. Well, thank you for those that are logging off. Thank you, Rose, very much. It has been a pleasure.
Likewise, Liz. Take care, everyone.